Good morning, good afternoon, and thank you all for joining us for this timely discussion on the CDC Advanced Molecular Detection Program, and particularly its role on genomic surveillance and sequencing of SARS-CoV-2. My name is Stacy Schultz-Cherry, and I'm a professor of infectious diseases at St. Jude Children's Research Hospital. I will be your moderator today. ASM is proud to support CDC's effort to bring pathogen genomics to the front line of public health. This technology enables us to detect disease faster, identify outbreaks sooner, and protect people from emerging and evolving disease threats. The AMD program has played an instrumental role during the COVID-19 pandemic. The SPHERES Consortium, developed by CDC, is a great example of how we are leveraging and building on existing AMD infrastructure and expertise to bolster our pandemic response. This public-private partnership draws from all sectors and brings together public health labs, academic research institutions, and clinical labs, as well as private sector entities, to sequence viral samples and ensure that we can track, trace, and understand its circulation around the country. Recently, ASM, with 48 other organizations, institutions, and companies, endorsed the Tracking COVID-19 Variants Act. And we thank the bill's sponsors, Senator Tammy Baldwin, Congressman Ami Bera, and Congressman Scott Peters. This important legislation authorizes up to $2 billion in emergency supplemental funding for the AMD program to significantly ramp up its existing work and partnerships to sequence a greater percentage of SARS-CoV-2 viral samples in the United States. This work is critical in light of the new variants that have emerged. Now, I'm pleased to introduce our special guest today, Senator Tammy Baldwin. Senator Baldwin has represented the people of Wisconsin in the U.S. Senate since 2013, and she is the first woman ever to be elected as a Wisconsin senator. Prior to coming to the Senate, she represented the 2nd District of Wisconsin in the U.S. House of Representatives for 14 years. And like my father and myself, Senator Baldwin's grandfather was a scientist at the University of Wisconsin. So she understood early on the importance of science, research, and public health for the betterment of human life. Throughout her tenure in Congress, Senator Baldwin has been a staunch advocate for healthcare and an unwavering supporter of both public health and medical research. Senator, ASM thanks you for all that you do, and we are pleased that you could join us today.
Thank you so much, Dr. Schultz-Cherry, and thank you to the American Society for Microbiology for hosting this webinar today. As all of you know, emerging COVID-19 variants represents a growing threat to the health and security of our nation. At the start of the pandemic, increasing our testing capacity was essential to our ability to track and slow the spread of the virus. The same is now true for finding and tracking these variants of the virus. The best way to identify, survey, and understand these emerging variants is through surveillance and sequencing of samples. Unfortunately, right now, the US is lagging behind other countries in tracking new and emerging variants of this deadly virus. I believe that we can and should be a world leader in efforts to combat pandemics through sequence-based surveillance. The CDC's AMD program is essential to this effort. And they've been moving in the right direction in recent months, but Congress needs to step up and do more. In order to better understand and track the virus variants and the threat they pose to public health, we need to dramatically scale up our sequencing work and make sure that we provide the CDC, as well as state, local, tribal, and territorial health officials with the resources and support that they need to protect public health and combat the next phase of the COVID-19 pandemic. And that's why I introduced the Tracking COVID-19 Variants Act, which, as Dr. Schultz-Cherry noted, provides the CDC with $2 billion to support robust national sequence-based surveillance. The bill would also support the work of health departments by providing technological assistance, guidance, and funding to increase capacity to conduct genetic sequencing, and would expand and maintain current and ongoing activities to analyze and interpret data produced through advanced molecular detection and genomic sequencing, including for emerging public health threats. Last week, President Biden announced that his administration intends to spend $200 million for CDC to increase its capacity to sequence virus samples. And I was pleased to see the House Energy and Commerce Committee, on which I used to sit, include $1.75 billion for the CDC to conduct, expand, and improve activities to sequence genomes, identify mutations, and survey the circulation of and transmission of viruses, including SARS-CoV-2, in their recently passed legislation. Now, I look forward to continuing to see the Tracking COVID-19 Variants Act progress as part of the larger American Rescue Plan. And I'm encouraged by all of the support from stakeholders and experts in the field. It is now my pleasure to introduce our next speaker, Dr. Greg Armstrong. Dr. Armstrong leads CDC's Advanced Molecular Detection, otherwise known as the AMD program, which is a $30 million per year innovation and modernization program established back in 2014. Through Dr. Armstrong's leadership, CDC has brought next generation genomic sequencing, bioinformatics, and related technology into public health in the United States. Now, amidst a pandemic, Dr. Armstrong and his team have played an integral role in the CDC's COVID-19 response. Over the past year, in addition to his role as AMD director, he also served as a deputy incident manager and the chief science officer for the agency's response. And his expertise, ingenuity, and vision have been invaluable. So thank you so much for the work you do, Dr. Armstrong, and I'll let you take it from here.
Senator Baldwin, I can't thank you enough for that kind introduction. So let me go ahead and start with AMD. What is Advanced Molecular Detection and the AMD program? The ability to sequence DNA has been around since 1976 with the advent of Sanger sequencing. And for almost 3 decades, Sanger sequencing was essentially the only technology available. Since 2004, however, with the advent of several technologies collectively known as next generation sequencing, or NGS, there's been a renaissance in this field. We can now sequence at rates many thousands of times faster than we ever could with Sanger sequencing. At CDC, we had been following this technology with great interest, and in 2011, commissioned a review, the Bioinformatics Blue Ribbon Panel, that confirmed the importance of sequencing to US public health. And this led to the establishment by Congress of the Advanced Molecular Detection program in the United States, with the objective to bring next generation sequencing and bioinformatics into the US public health system, first at CDC and then in state and local health departments. So if we go back in time a year to early 2020, as the pandemic started, where were we with the AMD program? Well, first off, at CDC, by that point, every infectious disease lab at the agency was using this, and next generation sequencing was being applied for essentially all infectious diseases of public health importance. The technology is very versatile. It covers pathogens across the spectrum, and has replaced many of the older technologies that we used to use to characterize pathogens. But in some ways, getting this done at CDC was the easier part. The harder part was getting it done in the wider U.S. public health system, and particularly in state and local health departments. So where were we a year ago? Again, 6 years into the AMD program. Well, we had already been working with state and local health departments for some time on sequencing capacity and on getting the microbiology workforce up to speed on genomics. All state health labs have sequencing capacity. In fact, well over 80 public health labs now have it. In fact, it's probably over 100. All of these labs are applying it to foodborne illness, and an increasing number are applying it elsewhere to antimicrobial resistant diseases, hospital infections, TB, or other pathogens of importance locally. Bioinformatics capacity, we'd also made a lot of progress, but had further to go. Bioinformaticians, this whole field is relatively new field in itself, and we're actually competing against Silicon Valley for bioinformaticians. But that said, we're able to attract a lot of talent just because of the opportunity to have a big impact. So we've established a network of 7 regional bioinformaticians, and an increasing number of laboratories are hiring bioinformaticians themselves. So we made some progress there. With the epidemiology workforce, however, we were really just starting to get done. For the last couple of years, we've taught for state-based epidemiologists a 2-day intensive course, and we're about to take that online when the pandemic hit. Furthermore, there are currently limited tools for integrating the genomic and epidemiologic data in order to make this data accessible to public health officials to use in their daily practice. So we were really just starting to make progress there. So moving on to SARS-CoV-2, to the virus that causes COVID. This is actually a good example of how sequencing is used in public health. So, absent from much of the debate so far in this space has been what are the actual objectives? What are we trying to do with the sequencing? And it's different at the national level than at the state and local level. At the national level, it's everything that we've been talking about for the last couple of months, detecting and tracking variants that have implications for vaccines, for therapeutics, for diagnostics, or that have important epidemiologic characteristics such as increased transmissibility or increased severity. At the state and local level, the objectives are actually very different. And in some ways, they are actually much more direct than they are at the national level. Genomics gives epidemiologists a more granular understanding of the epidemiology in their jurisdiction. It helps identify clusters that wouldn't normally be visible. There's no question that it's useful in investigating outbreaks in healthcare facilities, for example, or in workplaces such as food processing facilities, or in other congregate settings like homeless clinics or homeless shelters. In addition, it may be useful in supporting other public health operations such as contact tracing. So where do we stand right now with sequence-based surveillance here in the United States in terms of numbers? So the top row here is national SARS-CoV-2 strain surveillance. This is a system in which we ask 64 different health jurisdictions around the United States to send us a total of 750 samples every week. The big advantage of this particular system and where its real niche is that we don't just get the sequence data. Sequence data tells us a lot. But at some point, we actually need to get the virus itself so that we can do additional testing. So this is the one system that actually provides us with samples so that we can grow out the virus, not just for the characterization that we do at CDC, but we also make those viruses available to researchers and to industry through something called BEI resources. We're also working with national diagnostics labs, and we have contracts with 3. We're about to put out 2 additional ones and several other behind that. Currently, these labs are getting samples from around the country, essentially at random, and are sequencing about 5,000 of those, but we're expanding that up to about 25,000 in the next several weeks. In addition to all this, there are well over 40 state and local public health laboratories right now that are doing sequencing, and this number is increasing every week. We believe that they're sequencing about 4,000 samples per week. And then in addition to all this, there are other labs in academia and industry and in other sectors that are also sequencing the virus. They're sequencing about 4,000 per week, such that in all throughout the United States, there's about 14,000 per week, which corresponds to about 3% of the 450,000 cases in the last 7 days. And one thing I'll mention here is that really for the first time in my public health career, in fact, probably for the first time in history, there is a consensus to make this data public. Fortunately, we can make the genomic data publicly available without concerns about privacy. The privacy issues come around mostly around the data that go along with the sequence data itself. But this is really made, so we and others are making all this data publicly available through public databases. And we're taking advantage of the fact that researchers from around the world are monitoring this data, in addition to our own scientists at CDC. So let me just go through the 3 variants of concern that we're tracking currently. The first is B117. This is the one that was first sequenced in the UK on September 14th, and then was first identified as an emerging problem on December 8th. The characteristics of this virus is that it has increased transmissibility about 1.5-fold times that of other viruses, other SARS-CoV-2 viruses. In other words, of all the contacts of somebody with one of these viruses, they're 1.5-fold times as 1.5 times as much likely to get disease. This may also cause more severe disease. There's increasing data out of the UK that suggests that this is the case. Right now, we've found this in 44 states, but ever since we learned about this virus in mid-December, we've been telling states to anticipate that it's either already there, given how much how connected we are with the UK, or that if it's not there yet, that it will be there soon. The overall, this is accounting for, we believe, less than 5% of cases in the United States, but keep in mind, if it's 5% today, that means in 10 days it's going to be 10%, and 10 days after that it's going to be 20%. So we made some initial modeling estimates with modeling about a month ago that this would be accounting for about half of cases by the end of March or early April, and we're still on track for that. The next is B1351. This is the one that was first identified in South Africa. We have a lot less data about this, but that data is quite consistently shows that it has increased transmissibility in vitro and decreased neutralization in vitro. In other words, if you take serum from people who've either been infected with the virus or have been vaccinated, it doesn't neutralize this virus as effectively. However, keep in mind, somebody who's been vaccinated will typically have a neutralization titer of 1 to 400, 1 to 800, for example, which means that you have to dilute their serum up 400 or 800 fold in order for the virus to be able to grow in it. With this virus, those neutralization titers are decreased about 6-fold. So there's still, it's still believed that most vaccines are quite effective against this virus, although there's some data now about the AstraZeneca vaccine that is less effective. But this is an active area of research, and we're waiting for those results. P.1 is the one that was first identified in Brazil and is causing a large outbreak in Amazonas. Its characteristics are increased transmissibility, at least that's what the epidemiologic data suggests so far. Also, I would say probably decreased neutralization in vitro. And in Manaus, in Amazonas and in Brazil, they've seen an increased rates of reinfection there. Now, we're not stopping at those 3 variants. We're also tracking other variants, what we call variants of interest. For example, this first one, L452, is the one that's made some news in California. It is now accounting for probably somewhere around half of infections in California. It does appear to have increased transmissibility, but not nearly to the same rate as B117. So B117 is 1.5-fold as transmissible. This one is probably only 15% more transmissible. So in other words, if the doubling time for B117 is 10 days, doubling time for this is 25 to 30 days. B1525 and 526. 525 is one that we've seen. Actually, these are ones that we've seen in New York City and in Europe. They have some mutations that make them of interest to us, and we're tracking these with curiosity. We don't know if these are if there's increased transmissibility of these or not. In addition to this, we've learned a lot just in the last 2 months about what mutations have what effects on this virus. And we're in such a better position now than we were 2 months ago. And it's fair to say that 2 months from now, we're going to be in a much better position than we are now in terms of understanding these and in terms of understanding what we need to look for in surveillance for these viruses. So where do we go from here? So let me start out first with COVID-19. We've got to ramp up sequencing, which we're doing through several routes with industry, with academia, and with public health departments. We're continuing to increase the use of sequencing in state and local health departments. Which means both increasing the sequencing and improving the use of that sequencing data and the ability of health departments to make use of that data. We need to improve the national bioinformatics infrastructure. We are moving this to a cloud-based infrastructure, something that we had already started before the pandemic, but this is accelerating that. We need to improve training and support services. So I mentioned we had to stop the development of our online training course. What we've done instead is develop some short training videos for epidemiologists and public health departments. Those are available on our website right now for anybody who might be interested. And in addition, we're providing support for academic laboratories. Since September, we've been funding these labs. We've funded 7 of those so far from around the United States. These are mostly working with public health departments and doing surveillance for SARS-CoV-2, and are adding quite a bit to the to our understanding of what's going on. We are currently also expanding that network. So, what do we need to do after the dust settles from this? Before the next pandemic, before, let's say 5 years from now, COVID-26 comes along, what position do we want to be in so that we are better prepared in terms of genomics for this? So what we need to do between now and then is to continue to build the U.S. Genomics infrastructure. This is going to mean a lot of workforce development. We've made a lot of progress with the microbiologists. There's a lot more we need to do in terms of getting in this bioinformatics capacity. And there's, as I mentioned it before, a lot we need to do with the epidemiologists. Physical infrastructure, we've been building this up, but there's a lot that needs to be done, in terms of sequencing equipment and in terms of the equipment to automate the processes, or the processing of the samples before they go on to the sequencing equipment. In terms of improving connectivity in health departments so that they can take full advantage of the cloud and the opportunities that provides. We need to build out this cloud-based bioinformatics infrastructure. We need to further develop the tools for integrating genomic and epidemiologic data. And we need to take the experience that we've gotten with COVID-19 and build on these collaborations with academia and industry. This has actually been something that's been on our wish list for a long time. So, in short, what we need to do between now and the next pandemic is make sure that the use of pathogen genomics in the U.S. public health system is routine. And anybody in the military or anybody who does emergency preparedness will tell you this: you're always better off if you start with from a warm start. If we have public health departments that are using sequencing for the things I talked about before, for foodborne illness, for antimicrobial resistance, for investigating outbreaks of all sorts, for understanding the epidemiology of flu in their districts, then when the next pandemic hits, it's a small step for them to switch over, to pivot, to start applying this technology for whatever that pandemic is. So let me stop there, and I will stop screen sharing and hand things back to Stacy.
Wonderful. Thank you for a great presentation, Greg. Now it's time for some questions for our speaker. What is a variant, and why are there so many?
That's a good question. So, there's a whole hierarchy of how we classify organisms, going down to genus and then species, and then everything below species, there's actually no real consensus on what that is. But variants is basically, it's a category of SARS-CoV-2 in this case, that's defined by the genomics. And the way we oftentimes look at genomics is with a phylogenetic tree. You can imagine that as being like a physical tree. And if you took a physical tree and you started labeling the branches on that tree, the larger branches on that tree, that's what essentially would characterize variants. But for practical purposes, the variants that we're interested in are this virus is constantly mutating, so it's constantly generating new diversity. If you can imagine that tree growing and branching out and branching out. But occasionally it picks up genes or mutations that make it more transmissible. or that make it resistant to existing, or a little bit more resistant to existing antibodies in the population. And when that happens, that particular branch of the tree becomes of interest to us, and we start tracking that.
That's awesome. That was my next question: is what makes a variant of concern? How is this actually determined, and who does this testing?
Yeah, so there's no global consensus yet on how to define a variant of concern. So there's no solid definition of it, but in general, what it means is a variant. So it's a branch of the phylogenetic tree. It's a bunch of viruses and all of their descendants that have characteristics that make them of public health concern. So that are increased transmissibility. So with B117, for example, it has a mutation in the receptor binding domain. This is the part of the spike protein, which you're probably all familiar with at this point, that actually binds to the human cells. This mutation in B117 causes it to bind tighter, and that may be maybe one of the reasons, at least, for why it's more easily transmitted. So that's one characteristic. We're getting better at picking up at understanding how these mutations lead to these characteristics, but it's a very complex thing, and in general, it's probably the way this virus behaves is probably a combination of more than one mutation working at the same time. But that's essentially it. It's one branch of this tree that has something that makes it of concern to us, be it that it's transmitted more easily, it causes high mortality, it evades immunity somehow, or anything like that has public health importance.
So with that, how effective are our current vaccines against these various variants?
Yeah, so one thing I didn't get into is, and arguably should have in this presentation, is so how do we prevent these new variants? The answer is the same way that we prevent other SARS-CoV-2 viruses. So it's all the non-pharmaceutical interventions. So it's we know how these viruses are transmitted. These variants are transmitted exactly the same way. So to prevent transmission, it's physical distancing, it's mask wearing, it's avoiding large crowds, and so on and so forth. In addition to that, vaccination, we believe most of the vaccines, at least, are effective. So first off, for B117, the most common, the data are actually increasingly clear that the vaccines are probably just as effective against those as they are against previous variants. The differences are so minor that they're probably not going to impact vaccine effectiveness at all. For the other two, the Brazil one and the South Africa one, those, like I said, do, at least in the test tube, you need more serum in order to neutralize those, more serum from people who have existing immunity, which suggests that vaccines are maybe slightly less effective. But slightly less effective means that they're still very effective. But in truth, we won't know for sure until we get data from the field, the epidemiologic data, and these studies are in progress right now to look at how effective these vaccines are against these variants. The other thing I'll say is that viruses that have increased transmissibility, that does have implications for how we stop transmission, because it means that a virus like B117, in order to stop transmission, we need the same things that we do for other viruses, everything that I just mentioned, including vaccination. But if transmissibility is increased, that means that we need to do all of those with more rigor in order to interrupt transmission.
That's great. I think one of the exciting things that you mentioned about this consortium is that you are building relationships between academia and industry. Can you tell us more about what those relationships or developing those relationships will look like and what capacity needs to be developed going forward?
Yeah, so specifically the collaboration with industry. So the Spheres program was started by someone in our group, Duncan McCannell, who's on the line today. Back in April, May of last year, and it brought together groups from around the country that were doing sequencing. So it's public health, it's academia, it's industry, and non-governmental organizations. And it's been one of the big successes there has been to bring all these different sectors together to talk about priorities and to get consensus, for example, on the importance of making all of this data publicly available as early as possible. Industry's been a strong participant in that. Some of these reference labs that we are contracting with now have already been doing sequencing or had already been doing sequencing even before we started. They'd been doing it on a smaller scale using their own funding. But the fact that they were able to do that meant that they were in a better position when we did get the opportunity to fund them. They're in a better position to be able to scale up. So, like I said, right now we're focused on increasing the numbers, on increasing the amount of sequencing that's done around the U.S. But when we get up to about 25,000 is where we want to stop, at least for the time being, and reevaluate where we need to go, whether that's the right amount or whether we need to increase more than that. But it's also a time when we want to sit down and figure out, what are the strengths and weaknesses of this collaboration, and what do we need to do to make sure that we meaning the United States public health is getting the most out of it.
Great, thank you. One of the questions, which I think running a laboratory, this is an interesting one to me, is we've had supply chain issues throughout the pandemic, and they were highly publicized last spring. So how is this, or has it impeded effective sequencing for the surveillance of variants of SARS-CoV-2?
Yeah, it's a good question. So for the last few months, we've been coordinating with a group up in Washington that is tracking laboratory supplies and trying to forecast, shortages in the supply chain. Fortunately, the impact has not. There has been an impact. The biggest problem we have is actually in pipette tips. This is a kind of it's something that's used, in labs for just about everything. And the use of those pipette tips really went up when diagnostic testing went up in the United States. And at the same time, there were interruptions in the supply chain for that. And the sequencing uses those same supplies, those same pipette tips. And so we're continuing to track that. It is a concern. There are definitely shortages of certain brands of certain types where labs are unable to get those. For the time being, they've mostly been able to work around those, but it's something that we're continuing to track.
Yeah, it's definitely a problem. So here's a good question from an anonymous attendee who thanks you for your presentation and says that they believe Dr. Fauci has said that 75 to 80% of Americans need to be vaccinated to achieve herd immunity. So in your opinion, is there an expectation that this number will go up because of these new variants? And if so, what will this be, that we now need 85% of the population or even more?
Yeah, so that's an excellent question, and it's something, predicting, what level we need to vaccinate at for herd immunity is actually very, very difficult. It's just, society is so complex, and the interactions that people have with one another and how viruses are transmitted around are just so complex that there are limits to what we can do with modeling. But what I can tell you is this, just to give you a perspective of the impact. So let's say that without B117, we would need 70% vaccination coverage to produce herd immunity. With B117, that goes up to 80%. And that may not sound like much, but if you talk to anybody who's ever worked in the vaccine world, the closer you get to 100%, the harder it gets, because you're getting into populations that are harder and harder to reach for all sorts of reasons. So that means, so going from 70 to 80% may not sound like a lot, but to somebody who's worked in vaccination, reducing the number of unvaccinated from 30% to 20% is actually a big deal. It's I'm sure. Everybody in this field will tell you how important it is that we get as many people vaccinated as possible.
So here's I think a great question is, are you mainly tracking variants in the spike protein, or are you looking for mutations in other COVID-19 genes contributing to pathogenicity, transmission, replication, et cetera?
Yeah, so good question. We're understanding, we're mostly tracking the ones in the spike protein. So in terms of immunity, it's really the spike protein, and in fact, really just a very small part of the spike protein that's actually really important. It's that receptor binding domain that I talked about earlier. These variants have mutations all over the genome. They occur at random. And we've seen some interesting patterns that nobody yet anywhere around the world really understands. So, for example, in the first, maybe half or 60% of the genome is something that we call open reading frame 1AB. What it is, it's part of the genome that's translated into one big protein that then gets chopped up into several different proteins. And one of those, NSP6, non-structural protein 6, in all three of these mutant variants of concern, has a 3 amino acid deletion, which has occurred spontaneously in all three of these, which suggests that there's something about that. We really don't know what that protein NSP6 does. We're really not sure what the impact of that is. But for example, when this mutation I mentioned, B1525, showed up, one of the things that was interesting about it was that it has that 3 amino acid deletion in NSP6. So we're mostly looking at the spike protein, but following the other parts of the genome with a lot of interest. And they're, I should say, just a lot less understood than the spike protein.
Yeah, absolutely. So here's an interesting question. How does the mutation rate for COVID-19 compare to other pandemic potential viruses? For example, my favorite, influenza.
Influenza, yes. So they're both single-stranded RNA viruses, which just in general, the viruses can have, RNA, they can have DNA, they can be single-stranded, double-stranded. These single-stranded RNA viruses tend to be the ones that mutate the fastest. But SARS-CoV-2 only mutates at about a third the rate that influenza does. And that's because it actually has an enzyme in it that acts like a proofreader. So when when it's copying itself and it makes a mistake, the proofreading enzyme oftentimes will correct that. And this is why, influenza, evolves at such a high rate that we need to change the vaccine oftentimes every year. The same thing happens with coronaviruses that are endemic in the population. So, before this one came along, there were 4 that we knew about that were already in human populations. When you go back and look at those, they actually alter over time so that we end up getting reinfected with them. When we get reinfected, it's generally a cold. It's known to be maybe a little bit more severe than your average cold, but it's still just an upper respiratory infection. And so it probably does evolve the same way that flu does, but at a much slower rate.
Yeah, I like to think about flu, or think of flu as having spell check turned off constantly, right?
Yeah.
So there's been a couple, I think, really interesting questions along the same thread, and they relate to having a public database, something that anybody can access to see the variants that are spreading, the mutations, any information about them. And is CDC working on such a thing, or working with others so that we can get this data shared publicly?
Yeah, so the answer is it already exists. So there's 2 databases. The one that's truly open is managed by NIH. It was started, I think, in the 1980s or 90s. It's called GenBank, and it's run by the National Center for Biotechnology Information, NCBI, which is one of the institutes of it's within the Institute of Medicine, which is one of the institutes of NIH. At any rate, that normally is the database of record, and it's a truly open database. Anybody can go in there at any time. You don't need an account. You can search it. You can download the data. You can use it for whatever you want. And in fact, pharmaceutical companies, for example, or vaccine companies or diagnostics companies, these days, especially when they're developing a product that's based on sequences, they'll go in there and they'll pull all of that and use that, and researchers use that data as well. There's a second database that came about in the mid 2000s called GISAID, at gisaid.org, GISAID, which is the global something to share all influenza data. It's was established to protect the access and benefit rights of low and middle income countries. There was a concern in the mid 2000s that was sparked by in Southeast Asia that the richer countries were exploiting this genomic data that was coming out of low and middle income countries, and the low and middle income countries were missing out on the benefits of that. And so the second genomic database was eventually created that is also more or less public, but when you use it, you have to sign in. You have to create an account. You have to get approved. You have to agree to certain data access requirements. And if you're going to use it for any commercial purposes, you have to negotiate with the owners of the data to do that. Now that has become the de facto global database because just for a number of reasons, and that has the largest collection now of data on SARS-CoV-2. We at CDC submit to both databases. In fact, in the AMD program, we make it a requirement for anybody who gets our funding, and unless there's a compelling reason not to, the data needs to be made public as soon as possible. Ideally, in GenBank, but otherwise also in GIS8. And we're submitting to both databases as well.
Wonderful. I think there's been a number of questions related to how do you define or how do you know which samples you should sequence?
Yeah, it's a good question. So, if you think about the two levels of objectives that I talked about, the objectives at the national level and the objectives at the state and local level. At the national level, to monitor the emergence of variants in order to, inform decisions about diagnostics, for example. What we want are ideally random samples, a random set of sequences from all of the cases in the United States, so that we know what's circulating there. At the state and local level, it's actually very different. If you're using it there to guide your local response, you do need to know what's circulating out there. So a certain number of the samples should be at random, so that you have a good idea of what's out there in the community. But other than that, you want to target those samples. If there's an outbreak, you want to get usually want to get as many of the samples as you can from that outbreak. If you have questions about a contact investigation that's been puzzling for some reason, you want to get the samples from the case in the context. And that's where things are actually a little bit more difficult with the U.S. health system. So much of the testing is done in the private sector that laboratories that need to go get, public health labs that need to do that sequencing, they need to go to the private labs. But the private labs in general don't hold on to the sample after the diagnostic test is complete. And so that means that the public health departments have to make arrangements in advance with these labs to hold on to specimens. And this is an issue oftentimes for those private labs because they have limited freezer space. So, one of the things that we like to say is especially when sequencing at the state and local level, the hard parts are actually everything before sequencing and everything after sequencing. It's, getting the sample and getting the data that goes along with that sample. The sequencing is, like I said, is increasingly routine throughout the U.S. Health system. But then, after that, it's, bringing that within the firewall and integrating that with the genomic data. And finding the right tools to be able to integrate those and analyze and visualize those data, and having an epidemiologic workforce that understands how to interpret that information and translate that into public health action. So
we're coming to the end of our question and answer period. I want to really ask something that Vaughn Cooper also asks is, can you speak to how academia and industry can further contribute to the effort?
For those that are doing sequencing, encourage you to participate in spheres, but also to make the data publicly available, if at all possible. And we also, definitely encourage collaborating with state and local health departments. This is something we've actually been encouraging this collaboration since the beginning of the AMD program. In fact, we've benefited quite a bit from it, and it's something that we want to expand on, and that I think during the COVID outbreak, we've really been able to do that. So that, at least in my public health career, I've never seen a time where there's been so much collaboration between all three sectors.
It's fantastic. Thank you so much, Dr. Armstrong, for your presentation and for answering questions. I think we will continue to try and answer as many questions as we can through the question and answer. But before we close, we want to share remarks from Congressman Ami Bera, who represents the 7th District of California and could not be with us in person today. With Senator Baldwin and Representative Peters, Congressman Barra has championed funding for genomic surveillance and sequencing at CDC. Congressman Barra?
Hi, I'm Congressman Ami Berra from California's 7th Congressional District, the Sacramento suburbs. For the purposes of this call, I'm Dr. Ami Berra, and I want to thank the American Society of Microbiologists for their strong work and advocacy, not just in the genetic surveillance and sequencing effort, but also throughout this entire pandemic. It's been a pleasure working with the Society as we've looked at how to address SARS-CoV-2 and get ahead of it. And now that we're in 2021, to make sure we stay ahead of this virus. I also want to give a shout out to Mary Lee Watts from ASM, who's worked closely with our office as we've put together this legislation to make sure we are doing sequencing and surveillance with cutting edge technology. It's my hope and my understanding that we will see a relatively large appropriation in the American Rescue Package. We're already working with the CDC and others to make sure we stay ahead of these variants. So thank you for all the work that you do. Thank you for taking the time to explain to members of Congress and our staff the importance of why genetic sequencing and surveillance is so important as we deal with the pandemic that is in front of us right now, but also build in the infrastructure to survey diseases that have been around for a while, but also to be prepared for that next pandemic. Thank you, everyone. Be safe, be kind to one another, and be well.
Thank you, Congressman Barra. In closing, I want to say thank you again to Dr. Greg Armstrong and Angela Oliver from CDC, to Senator Baldwin and to Congressman Barra, to all of the ASM staff, Justin, Mary Lee, Alan, for making this possible, and thanks to all of you for joining us.